Hello, everyone. I think we can start now, and I will continue on admitting the rest of the people as time comes. Thank you for joining another lecture in our clinical series we're organizing. Today, we will be talking about polycystic ovary syndrome, and we have with us Dr. Liya Megrelishvili. She graduated from the first faculty of medicine in Prague in 2018. And then she went on to begin her residency specialty in obstetrics and gynecology at the General University Hospital and First Faculty of Medicine Hospital in Prague. Without further ado, I don't want to waste our time. I will yield the floor to her. And thank you so much for joining us today. Thank you for your time and effort. And we're all very excited to hear about our lecture today.
Thanks for the introduction. As you've already said, my name is Dr. Megrelishvili. You don't have to remember my last name. Nobody does. Nobody, not even people that I work with, which is a plus and a minus in some sorts of ways. But without further ado, I mean, there's like 70 people already here, so we might as well start. So the talk of today's lecture is going to be about polycystic ovary syndrome. And let's start with saying what it is. And if I can get my laptop to cooperate, I will get to the next slide in a second, which is working 5 minutes ago. Yeah, it's working now. So what is PCOS? I'm going to be shortening it to PCOS from now on, because it's just a mouthful. It's an endocrine disorder, which is one of the most common in women of reproductive age, affects about 8% of women overall. Depending on the population that we're talking about, it can be from 5 to 11%. The exact cause is actually unknown. There are some factors that could be either inherited or environmental that play into a person developing PCOS, and some of those factors are listed on the screen. Either insulin resistance, where excess insulin can actually increase androgen production, which would cause difficulty with ovulation. Some studies have shown that a low-grade inflammation that is happening in women with PCOS can sort of attribute to it. Also, heredity can play a role, whereas we can look at people who have a family history of relatives with PCOS, obviously excess androgen from outside or inside, and some reproductive system abnormalities with levels of luteinizing hormone and high levels of androgen, which interfere with the normal function of our ovaries. And this is a table that you could look at, and it kind of encompasses everything that I've already said. We can look, if you can see on top, we have some inherited factors and then some environmental or acquired factors. All of them kind of play into presentation of PCOS and then clinically evident PCOS. I don't know if that presentation is going to be available. I'm guessing it's going to be available to you, so you don't have to like print it out or take a screenshot, so you can actually have it with you for the rest of however long you might need this information for. And there are other conditions that are associated with increased prevalence of PCOS, which are infertility due to lack of ovulation, obesity, diabetes, be it type 1, type 2, or gestational diabetes, obviously a higher risk of a woman, if she does get pregnant, developing gestational diabetes in her pregnancy, first-degree relatives with PCOS, ethnicity, and some drugs are said to be linked with people developing PCOS. Which in this case kind of brings me to this slide, where I think it's more of a, we still don't know which comes first, the excess androgen and then PCOS, or PCOS causing excess androgen, or it's like more of a situation of which came first, the chicken or the egg. But then again, as the other pictures shows, we already know that the eggs existed before chickens. So I feel like it's just a matter of time until we find it out. So just like, we'll see. And now to the thing that everybody loves and cherishes and knows by heart, obviously, a menstrual cycle. We need to kind of go into it. I won't go into it for too long or too detailed, but we just need to kind of dust it off and remind ourselves about how normal menstrual cycles work in order to be able to talk about PCOS and all the problems with gonadotropins and hormone levels that are out of norm with PCOS. So as this table shows, we have some hormones that are produced by pituitary gland, and some hormones that are produced by the ovaries. We're going to start with FSH, which is a follicle stimulating hormone. In the beginning of the cycle, that normally starts with the first day of the menses. FSH is released in polycystic, and it creates a level that stimulates ovaries to produce follicles, basically from primary follicles to theca follicles to then tiny smaller antral follicles that somehow get to the point of like 5 to 8 millimeters, and then from that point on, one of those follicles would then go on to become the dominant follicle. And this is where LH comes in, which is luteinizing hormone. During ovulation, at the time of ovulation, there is a very quick, like a rapid increase of LH, a peak of LH that causes ovulation. And then after that, it drops quite as fast as it rose, basically, and hence ovulation occurs. And afterwards, the site of ovulation then turns into a corpus luteum, which then produces progesterone, which means that progesterone rises after ovulation. And then afterwards, if pregnancy does not occur, corpus luteum then turns into corpus albicans, progesterone falls, blah, 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 menses happens again. In a nutshell, this is the menstrual cycle. We didn't talk about estrogen, but basically estrogen obviously rises towards ovulation, because another thing that we need to remember that in the antral follicles that we have two types of cells, theca cells and granulosa cells, and those are the ones that produce, the granulosa cells produce estrogen, and the theca cells produce testosterone. Not directly, but that's just what you need to work with now. So we're not going even into more detail about this. So remember that antral follicles produce both estrogen and testosterone, and normally we only have those antral follicles around like 5 to 8 millimeters, and then one of them becomes a dominant follicle. Okay, let's go further. And in PCOS, multiple preantral and antral follicles, their growth is arrested at that diameter, about 5 to 8 millimeters. They accumulate in the ovary, and usually it happens in subcortical parts, in the peripheral parts locations. So it kind of looks like an increased stroma and a lot of tiny little follicles on the outside. Hence the term, but we're going to talk about this term in a second. None of these small follicles are capable of growing beyond that size, so there is no dominant follicle, hence no ovulation, hence the increase of sorry, not the increase, but an imbalance of estrogen, progesterone, LH, FSH, and all of the other, basically all of the hormones that we just mentioned. And this is another table. So basically in a normal cycle, you have a normal GnRH pulse generation where GnRH is giving a signal to FSH and LH. A normal LH in a normal cycle causes an ovulation, whereas when we have pathological gonadotropin regulation in PCOS, the LH output kind of like happens all the time, but not enough for it to cause an ovulation. Basically, what happens, follicles develop pathologically. There are no corporal lutea, basically, so lower progesterone, numerous cysts, which are not cysts, they're the follicles that haven't developed. And because we have a lot of preantral follicles, and those preantral follicles obviously have a lot of those theca cells that we talked about, they obviously produce more testosterone. This is what is causing excess androgen in people with PCOS. I don't know if we're going to be doing questions throughout the whole thing, or we're going to be doing them afterwards, but if you do have any questions, we can come back to any slides later on and you can ask them, obviously. So as I was saying before, many, obviously not all women with PCOS have abnormal gonadotropin secretory dynamics. So normally there is an increase in LH levels, and because there is such an increase as a base in LH, we need a peak for them to ovulate. But because there is an increase, they cannot ovulate. They don't normally ovulate without that the said peak. That is not happening because the pulses are infrequent and their amplitude is different, and usually the ovulation only occurs maybe like 3-4 times a year with people with PCOS. Obviously, we don't really do LH testing to diagnose PCOS because it can depend on a lot of factors, such as the time in their period, the activity of the ovaries, BMI, and other things. But normally you can find LH to FSH ratio being over 2, which is normal in a normally menstruating woman. But that is not a criterion for a diagnosis. But just keep in mind that LH is usually elevated in PCOS. So what might a patient present with if they think they might have PCOS, or they come into our clinic and we think they might have PCOS? First of all, it's oligamenorrhea, and sometimes even amenorrhea, which is defined as, oligamenorrhea is defined as having less than 9 periods a year, which means that usually their cycles are longer than 35 days. Hyperandrogenism, basically anything you can think about, but usually are the general 3 are acne, hirsutism, and male pattern baldness. And obviously clinical presentation, depending on when the patient comes to find us, they can already have some risk factors and some cardiovascular problems, including they could be obese, they can have prediabetes, they can have dyslipidemia or sleep apnea. And obviously all of these symptoms are worse in obese women. So the menstrual dysfunction that we talked about, that women with PCOS usually present with oligamenorrhea, it usually logically typically begins around puberty, and menarche can be delayed. Sometimes the PCOS can develop later, especially in response to substantial weight gain, but normally we look at people who start menstruating, and the onset of PCOS is usually with menarche. And the menstrual pattern, as we talked about, is oligamenorrhea or amenorrhea, basically with no menstrual periods for 3 or more consecutive months, which is a huge risk factor for endometrial hyperplasia. We're going to be talking about it later. And obviously, because we're talking about ovarian dysfunction, women with PCOS often then experience more regular cycles closer to the time when you'd expect them to go into perimenopause, so after the age of 40 years. As we talked about hyperandrogenism, the most common signs are hirsutism, acne, and male pattern hair loss, which means temples and on the back of their head. They can have elevated serum androgens with testosterone, androstenedione, DHA, but we don't test for all of them, and I will talk about it later. And most women with PCOS will have both clinical and lab results that show that they have hyperandrogenism, with signs of more severe androgen excess, as like clitoromegaly or deepening of their voice, or a sudden onset of hirsutism can be a sign of something more serious going on, as something like a tumor that is producing or secreting androgens, and that's a part of our differential diagnosis, but that's something that is not the part of PCOS. Basically, that is something to keep in mind if you've already been following that patient and then suddenly you see them with a sudden onset of those symptoms. What is hirsutism? Basically, it's defined as excess terminal body hair in a male distribution. It has to be terminal hair. It doesn't, it's not that somebody is just slightly hairier than the rest of the population. It's terminal hair, basically like you'd expect like beard hair, basically, in male distribution. So male patterns above upper lip, chin, around your nipples, mid-sternum, lower abdomen. Also, we need to talk about racial variability. We have a lower threshold for hirsutism in, say, Asian women, whereas Mediterranean women or non-Hispanic white women, they have different patterns of hirsutism, and we can talk about it later. I will show you a few pictures. Approximately 40 to 85% of women with PCOS are overweight or obese compared with age-matched control groups, and most of them present with insulin resistance in both thin and obese women, and they also are at an increased risk of type 2 diabetes. And we will talk about how we screen for those and how we follow up those patients later on. I'll just check the chat. Is PCOS the most common cause of hirsutism? It probably is. We will talk about differential diagnosis for hirsutism, but in general, PCOS being one of the most common endocrinopathies in women of reproductive age, I would probably first think horses, not zebras, so PCOS, but there are obviously other conditions that we're going to talk about in differential diagnosis of PCOS that can also obviously cause hyperandrogenism and hirsutism. I hope that answers your question. So we're going to be talking about diagnosis, and diagnosis is one of the most, I'd say, not controversial topics, but there's been a lot of changes in the diagnostic criteria for PCOS in the last years, in the last like even 10, 15 years. And obviously some of you might have heard about Rotterdam criteria, but those have changed, and we're going to talk about like ultrasounds and everything. So diagnosis is made based on patient history and a physical exam. And the most important thing that you need to remember, that you need to exclude other conditions that could mimic PCOS, such as disorders that can cause oligoovulation or anovulation, and again, hyperandrogenism, thyroid disease, non-classical congenital adrenal hyperplasia, hyperprolactinemia, and androgen secreting tumors. And we're going to talk about each one of those a little bit in a while. And as I've said before, the Rotterdam criteria are still most groups prefer with the Rotterdam criteria, even though in 2008, Androgen Access Society kind of modified them slightly. And with the Rotterdam criteria, you need to have 2 out of 3 of the following criteria, which is the fact that the woman has to have oligo or anovulation and clinical or biochemical signs of hyperandrogenism. And the third one is polycystic ovarian morphology, which is exactly what everybody's kind of cannot reach a consensus about, with does the ultrasound count as a diagnostic criteria for PCOS. So for now, go with oligo ovulation, biochemical or clinical signs of excess androgens after exclusion of other conditions. So those 3 have to be present for you to have a diagnosis of PCOS. And we're going to talk about ultrasound in a second. Cysts can be, so there's a question, cysts can be all over the uterus or only in ovaries? Cysts don't normally form in uteruses in general. And PCOS is an ovarian condition. So yes, only ovaries, no cysts in the uterus. Cysts, I don't even think cysts can form in uteruses, to be honest. Correct me if I'm wrong, but I think I'm right. Yes, there is a question, is it possible for women with PCOS to have spontaneous ovulation sometimes? Absolutely. As I said, they present with oligo ovulation, which means if they have less than 9 periods a year, oligomenorrhea means that your period only comes after an ovulation. That's what we call menses. Everything that comes, any other bleeding that doesn't come after ovulation is just bleeding of what we call, I don't know the proper term, but it's basically because of the drop of hormonal levels. And we only count menses as a bleeding that happens after ovulation. So women with PCOS, yes, they do have spontaneous ovulations, but they usually have them maybe like 3 or 4 times a year, depending on how often they get their cycle. If their cycle is like 45 days, and then they bleed like every 45 days or so. Some of those cycles might not be ovulatory cycles as well. So normally, yes, there's like a consensus that they have an ovulation every, say, 3-4 months. So obviously they can get pregnant spontaneously. It's just going to take a lot longer. So obviously they need to use methods of contraception if they wish to not get pregnant. And we're gonna talk about inducing ovulation in women with PCOS slightly later on. And I hope that answers your question. So yes, they have spontaneous ovulations. Okay, so we talked about this and the ultrasound. And yeah, so now differential diagnosis. The conditions that can kind of mimic PCOS in the criteria that we talked about is non-classical congenital adrenal hyperplasia, thyroid disease, hyperprolactinemia, androgen secreting ovarian and adrenal tumors, and ovarian hypertrichosis. With thyroid disease and hyperprolactinemia, those would only mimic the oligomenorrhea, not the hyperandrogenism, basically. That would kind of exclude them from the differential diagnosis, but you do have to think about maybe they're just racially more hairy and they have thyroid disease, and think about them not maybe having PCOS but having those two conditions combined. The clinical presentation of non-classical congenital adrenal hyperplasia is similar, sometimes even identical to PCOS, but it is a lot less common, but should be ruled out because there are risks that the offspring of people that have this disease could be affected with a more severe classic deficiency. The lab test that you would do for this is stated in brackets, but I don't know if you need this information, but basically you take a lab test of morning hydroxyprogesterone, and most importantly in high-risk women, as we talked about, Mediterranean, Hispanic, Slavic, and Ashkenazi Jewish women. And we're going to talk about it slightly later on, about all of the lab tests that you might need and the lab tests that you definitely do not need in people with PCOS. With androgen-secreting tumors, they typically present with recent and rapid onset of severe hirsutism, sudden progressive worsening of it, or symptoms and signs of virilization, which is balding, acne, clitoromegaly, increased muscle mass, deepening of the voice. Again, some of the lab tests and lab findings can be found in smaller print. If you need it, it's in the presentation. I'm not going to go into detail because I don't think that's relevant right now, because we're just going to be talking about differential diagnosis for a couple more seconds. It's important to note that those are primarily found in women in post-menopause. So think that with women after they come to you if they're not menstruating anymore. Now, diagnoses. As I talked about, all the phenotypes and the Rotterdam criteria that were created in 2003, the most recent criteria and the ones that people adhere to right now are the ones that were revisited in 2006, 2008, which are the Androgen Access Society criteria, which we talked about, exclusion of all other things that can mimic PCOS, and then clinical presentation of hyperandrogenism or laboratory presentation of hyperandrogenism, and oligo or amenorrhea, or anovulation, basically. Just think about all of those, and we're going to talk about the ultrasounds in a second. Again, more definitions, and here you can see the AES definition that was finalized in 2008, and this is the most recent one. It's not that different to Rotterdam criteria, except it doesn't count for the polycystic ovaries on the transvaginal ultrasound. And this is what we're going to talk about, the polycystic ovarian morphology, which is the way polycystic ovaries sometimes look on transvaginal ultrasounds. It is performed in some women. Normally, at least in Czech Republic, it is performed on women during a regular checkup to determine if they have any lesser pelvis anomalies. And if they have polycystic ovarian morphology, which is the appearance that I talked about before, the increased stroma and the large amount of small follicles on the periphery on the ultrasound, if they are still presenting with hyperandrogenic symptoms, but normal menstrual that are not presenting, if they are presenting with hyperandrogenic symptoms and maybe are not having normal menstrual cycles, yes, that could be grounds for thinking this could be PCOS. But if you just see those ovaries in a woman who has regular menstrual cycles, has no other concerns, isn't hairy, isn't balding, doesn't have severe acne, this is not something that you need to evaluate further. And as we were talking about the Rotterdam criteria, people couldn't even come to a conclusion on what number of cysts and follicles in each ovary could be considered polycystic, because in normal functioning ovaries, especially in young women, you will see a lot of follicles. But in 2018, I think the threshold of around 20 to 25 follicles was set. But they're still kind of arguing about should we be counting the number of follicles plus their size. As I talked before, they need to be smaller than 8 or 9 millimeters, or do we count the volume of the ovary and blah blah blah. But basically, for now, PCOS is not an ultrasound diagnosis. So an ultrasound finding of something that looks like PCOS without other presentations of PCOS does not merit further evaluation. We don't need to be thinking about PCOS if she does not present clinically as PCOS. So finally, some pictures. So picture A here would be typically a polycystic ovarian morphology. So we talked about increased stroma, the thing in the middle, and under the cortex, around the tunica albuginea, basically. Peripherally, you have tiny, small follicles. Same here on the picture below. This here is a completely normal ovary with the dominant follicle. You can see that the other follicles are still larger than the ones in the picture A, but the dominant follicle is, I'd say, I cannot tell you how large it is, but dominant follicles are usually over 12, and then they keep growing until they release the egg around 20 millimeters, when they are around 20 millimeters. Right. Okay, so now that we know we don't really know what causes PCOS, we know how it presents, the pathophysiology of it, and the clinical manifestations. There are obviously some complications that come with it. We can talk about infertility, diabetes, or pregnancy-induced high blood pressure. People with PCOS have a higher risk of miscarriage if they do get pregnant, or premature birth. They have a high risk of non-alcoholic steatohepatitis, of metabolic syndrome, diabetes, sleep apnea, depression, abnormal uterine bleeding, even endometrial cancer. All women who are diagnosed with PCOS should be monitored by a healthcare provider because of all the complications that PCOS can have. So we're not even just talking about people with PCOS who are obese. Other people with PCOS can still have, say, a higher increased risk of endometrial cancer and other problems that we just talked about. So they need to have follow-ups and monitoring by their healthcare provider for the rest of their life. When we are assessing their cardiometabolic risk, we need to obviously monitor their blood pressure and body mass index on initial diagnosis, and after that, we need to do a lipid profile at initial diagnosis, to our oral glucose tolerance test in all women. We don't do fasting glucose because that could still be normal in people with prediabetes. But if we cannot do the OGTT, we can do a fasting glucose and then obtain that together with glycated hemoglobin, but do an OGTT at the earliest possible possibility, basically. We cannot just be okay with them having that test once. They need to obviously be rescreened at least once every 2 years. And some studies say that they need to be also at least given a questionnaire about symptoms of sleep apnea, because sleep apnea can obviously cause a lot of cardiovascular problems as well. So maybe give them a questionnaire and then refer them to like a sleep medicine clinician. How do we treat PCOS? PCOS has to be treated, but depending on the concerns of your patient, it can be treated in a few different ways. So we can either treat the patient who has PCOS, wants to get pregnant. So we're treating their infertility, even though they're not really infertile, they just have less ovulations, as I talked about. We can also treat the fact that they're not menstruating regularly, which to some people could mean that, oh, why is that a problem? Well, it's, you know, less problems with menstruating like once or twice a year, which is fine if you have periods once or twice a year with an IUD or combined oral contraceptives, but not in a situation where uterine lining is still growing. Or we also can treat the fact that they have clinical presentation of hyperandrogenism, such as hirsutism and acne, or balding as well. So let's talk about, first of all of the patients that we have with PCOS. Unless their BMI is normal, we suggest weight loss, which could be harder with people with PCOS, but even a 5 to 10% body mass reduction can increase their chance of spontaneous ovulation and decrease their risks, the cardiovascular risks, and all of the clinical presentations of their disease. The less they weigh, to a certain extent, obviously, the better the presentation of their disease could be. Medication that we can give them. Obviously, again, talking about people right now that do not want to get pregnant. The first line of medication after lifestyle changes is combination birth control pills. Pills that contain small amounts of estrogen and progestin. They decrease androgen production, regulate the estrogen that they already are producing, and lowering the risk of endometrial cancer by preventing hyperplasia and correcting abnormal bleeding that happens with oligomenorrhea. Also, with lowering the androgen production, they help with acne and hirsutism. You can obviously use a patch or a vaginal ring that combines estrogen and progestin. It doesn't have to be an oral contraceptive, but obviously an absence of pregnancy should be documented before you start on contraceptives, because again, as we talk, people with PCOS absolutely can get pregnant. It's just harder. Progestin therapy, which is not a combination birth control, can be an option for people who do not wish to take combination birth control pills because for some reason they don't want to be taking estrogen, or some other reason that they might have, or they want to get pregnant, or whatever reason they might have. Basically, progestin therapy is us taking progesterone and replacing that peak that we talked about that happens with after ovulation, where corpus luteum is created. We give them progesterone so they have that progesterone that they would not normally produce because they are not ovulating. And then after we take that progesterone away, after the progesterone levels fall, they have a normal menstrual bleeding with all of their endometrial lining sloshing away and not causing endometrial hyperplasia. Basically, we can do that every 2 to 3 months. That should be enough. They don't even need to be taken it every month. We give it to them for 10 to 14 days in the second part of their cycle. So we kind of trying to mimic the normal menstrual cycle and trying to regulate their period. But this therapy does not improve androgen levels because, again, we're not introducing external estrogens that can kind of like lower the production of androgens. And this pill cannot prevent pregnancy, obviously. But obviously, if you are still concerned about taking estrogen, you can have an IUD with progesterone or a progesterone-only pill, hormonal contraceptive pill with only progesterone, if you also wish to avoid pregnancy. But still, again, we're talking about people who do not wish to treat hyperandrogenism and they don't have acne or hirsutism. And here are the names of the progestins that we usually give to them, because as you know, combined oral contraceptives have a low level of estrogen and then progestin. And depending on the progestin, basically, you can kind of modify the progestin that you give to people. And according to that, you can either give it, depending on that, you can see a person, say a person with severe PMS is going to get a different progestin than a person with severe endometriosis. So normally the progestins that we give people with PCOS are the ones with no androgen activity. The last three here, the Dienogest, drospirenone, and Megrelishvili, are the ones that we give normally in combination with estrogen. As a mini pill, we usually give norethindrone. The rest have really. Is there a question? No. The rest have a very high level of androgenic activity, so those are not usually the first choice if we're trying to combat hyperandrogenism. So choice of oral contraceptive is 20 or 35 micrograms of estradiol combined with a progestin, again, norethindrone or other progestins that have a lower level of androgen activity, but similar risk of venous thrombosis compared with levonorgestrel containing combined contraceptive pills. Basically, this is all that I've already said. If we're talking about doses of estrogen, with younger people, we'd go for a slightly higher doses of estradiol because we need to suppress the production of androgens in their ovaries, and we might not get that with just the 20 micrograms of estradiol. So that's the only kind of thing that you need to be thinking about. Other medication that we might give them if the combined oral contraceptives are not working, the second drug that we might give them is spironolactone in a dose of 50 to 100 milligrams twice daily. It is usually added after 6 months of combined contraceptives if they are not working, or if the patient is not satisfied with the level of the clinical response that they're having. Other antiandrogens are finasteride, dutasteride, flutamide, but obviously they have other side effects, should not be used if you cannot be 100% sure that you're not pregnant. And other drugs can also be used as GnRH, but this approach, although effective, is quite costly, so is not used quite often. So if you're just listening to this and trying to get through an exam, I'd say spironolactone after 6 months of failed or a person not being satisfied with combined oral contraceptives is enough. How long is it recommended to administer combined oral contraceptives? As long as they wish to not become pregnant for. So technically they can be taking it for the rest of their life if they never wish to get pregnant. Or until they choose that now they want to go onto a progestin only pill, or they want to have an IUD or something else. Contraceptives or oral contraceptives are not the risks of thrombosis usually is highest throughout the first year of you taking oral contraceptives. So if you're on them, you can stay on them for as long as you want, up until the point where you decide that you want to become pregnant, you wish to become pregnant or try for pregnancy. But obviously the symptoms will come back as soon as you cease to be taking them. Okay. Again, and then we're talking about people who do wish to get pregnant. In people with PCOS, we can easily induce ovulation because this is the only stone that's kind of in our way of them getting pregnant. Well, technically, it is the only known thing that we, for now, know that they cannot get pregnant for. it obviously can be other reasons for like a pathological spermiogram or something like that. No, combined oral contraceptives do not cure the disease. The symptoms will come back. Maybe not immediately after ceasing COS, but quite, I'd say, in 6 months to a year, the symptoms might come back. They might not be as adverse, but they surely will. There is no cure for PCOS. There is only management of symptoms and problems that person might be having. Okay. So, and how do we induce ovulation? One of the most common drugs that are used for ovulation induction is clomiphene, which is an oral anti-estrogen that is taken during the first part of menstrual cycle, usually 2nd to the 6th. Some resources say 3rd to 7th day of your cycle. So say you start your period, first day of regular bleeding, on the 2nd day you start taking this pill, and this creates a dominant polyp. You are ovulating. Other anti-estrogens are letrozole, basically primarily a breast cancer drug. You can also use tamoxifen to induce ovulation, interestingly enough. Some studies show that metformin can improve insulin resistance and improve the rate at which the patient will be losing weight. So therefore would improve their chances of spontaneous ovulation, but metformin alone cannot induce ovulation, but some studies show that it can help. And then if that doesn't help, we can obviously inject gonadotropins as a normal IVF cycle with either regular stimulation or minimal stimulation. So if we're talking about what is our first line treatment and what we could try if that fails, obviously, as I said before, first things first is weight loss. Weight loss and weight loss and weight loss. It does not increase the risk of multiple pregnancies, and it doesn't cost you much. The second thing in the first line treatment is letrozole or clomiphene. Low risk of multiple pregnancies and low cost. It doesn't cost much, at least not in Czech Republic. Second line is follicle stimulating hormone injections, which are costlier than letrozole, and the risk of multiple pregnancies are higher, and as in regular, general, and IVF. And second line is ovarian drilling, which is a laparoscopic procedure that is performed on the ovary that we're going to be talking about later in a second, actually. And regular IVF could be the third line. It's very costly and is has a high risk of multiple pregnancy. But obviously, if we just transfer a single embryo, we can avoid that risk. The laparoscopy that I was talking about in PCOS was ovarian drilling, which came after a wedge resection in the ovaries. That was a standard treatment for infertility in PCOS in the past, but it was abandoned because of a high risk of adhesions and obviously high costs, and the fact that clomiphene was just as effective. As a substitute for that resection, ovarian drilling was introduced. It's an operation where you surgically literally drill the ovary, but there's still no consensus on how many punctures you have to do, at what rate, at what how many times do you need to do that. The thought behind it is the fact that you kind of like break the outer layer, the tunica albuginea that covers the ovary, which is thought to kind of like prevent the ovulation from occurring. But obviously it's a disadvantage of any surgery, be it laparoscopic or other. There are risks of adhesions and risks of infection. Side effects of clomiphene and letrozole. Obviously there are, not that I can think of anything from the top off the top of my head, but no, nothing that I can think of at the top of my head, but I don't think there is any medication that you can take without any risk of any side effects or complications. But there are very, very few that I've encountered in my short tenure so far. Is PCOS genetically inherited? I talked about this for a little bit. We don't really know what causes PCOS, but there is a chance that is connected to somehow genetically. There are certain inherent factors that can come into play with PCOS, because there is a high risk of you having PCOS if somebody in your family already does. Okay. Okay, so, and the last resort that we can go to if weight loss and ovulation induction doesn't help, we can go to IVF, but women with polycystic ovaries are at a quite highly increased risk of ovarian hyperstimulation syndrome, which is the biggest complication of any IVF cycle, which is basically a situation where you've overstimulated the ovary and you start losing protein and you develop ascites, and you can possibly die from this complication. So this is quite a scary state to be in. So there are a few ways that you can prevent that, usually lower doses of FSH, and a few drugs that you can then give a patient if you think they're at a high risk of OHSS. And the fact that if they're in the IVF cycle, you don't transfer the embryo in that cycle, but you wait until their ovaries come off the stimulation for a little while and they're in a calmer state. Because the thing that causes OHSS is basically the HCG molecule. Now, if we're talking about excessive hair growth and how we treat that, we already talked about what hirsutism is and how it is defined, and there is a huge racial variability. There's going to be a picture here, so this is what hirsutism normally looks like, and it is usually evaluated on the Fairman-Galway score. Here you see 9 areas on which we score the person who has hirsutism. I think it's been revised recently to include, oh no, it was originally 11, but it was revised recently to be decreased to 9 body areas. So upper lip, chin, chest, upper back, lower back, upper abdomen, lower abdomen, upper arms, thighs, and so legs and forearms were removed recently. And as we talked about, it can be rated from 0 to 4, and we have a lower threshold with Asian women, and obviously a higher threshold with the Mediterranean women, and so on. How we manage it is, again, I talked about birth control pills. They decrease the production of androgen. Spironolactone can be added in 6 months if that's not enough. There's a cream that contains eflornithine. That's basically a drug that treats sleeping sickness, but can also slow the growth of facial hair, but it only works while you are constantly applying it, meaning as soon as you cease applying it, the hair will come back. Also we're talking about like laser hair removal and electrical hair removal, all of the depilation possibilities of hair removal. And again, if we're talking about women with hirsutism, we might measure some serum androgens to rule out other possible causes of hirsutism. And there was a question here, which are the most common causes of hirsutism, and if it's the most common cause of hirsutism, and yes, PCOS is the most common cause of hirsutism. Other ones are non-classic hydroxylase deficiency and classic hydroxylase deficiency, and other problems that we talked about: acromegaly, drugs, Cushing's disease, severe insulin resistance syndromes. So that has to be ruled out, but PCOS is definitely the most common cause of hirsutism in women. What labs might we need in women who are presenting with symptoms that we think they might have PCOS? If we're talking about a woman who comes in and they have hirsutism, but they have normal menstrual cycle, so they most likely will fall in the category of PCOS or idiopathic hirsutism. We could be all good with just total serum testosterone. If we're talking about a person with oligomenorrhea and hyperandrogenism, we take total serum testosterone and an early morning hydroxyprogesterone, again to exclude the non-classical congenital adrenal hyperplasia. And also, if we are talking about oligomenorrhea as it is, we also need to exclude other problems that might cause oligomenorrhea, such as amenorrhea. So we take HCG to exclude pregnancy, prolactin to exclude hyperprolactinemia, TSH to exclude thyroid problems, and FSH. In general, it is not necessary to measure LH, as I talked about, because the ratio will be kind of off, but the ratio of LH to FSH is not the criterion for the diagnosis of PCOS. Other androgens that we might test are free testosterone, but it is really not suggested because the tests that are now available are not very reliable. It could be done by calculating free testosterone from total testosterone and sex hormone binding globulin, which we can measure in women with abnormally low, in women with PCOS, but the only thing that it would give us is the fact that we know that they might have the most severe phenotype, because the testosterone in their blood is not bound to sex hormone binding globulin, meaning they have more testosterone, excessive testosterone in their bloodstream. DHEAS does not affect management at all, and androstenedione is not suggested because there is absolutely no clear role of its role in management of PCOS. So basically, the only thing that we might need to measure is serum total testosterone and hydroxyprogesterone in the morning if we want to exclude classical congenital adrenal hyperplasia. Again, some women seek advice when they're already taking pharmacotherapy, and when that's the case, you kind of have to think about, do we really need to be taking lab tests with them because they either are already diagnosed with PCOS or already treated? Because for you to be able to take their blood and have results that are not skewed by the hormones that they're taking, you need to tell them to stop medication for 4 to 6 weeks, which can be, in case of combined oral contraceptives, kind of illogical, because again, you're exposing them to the risk of them starting on combined oral contraceptives for the second time, and those lab tests are not going to tell you more than the clinical presentation, because again, clinical presentation should be enough for you to have a diagnosis already. Another thing I think that's going to be one of the last slides that I'm going to show you is anti-Müllerian hormone, which again, it's not a thing that we use to diagnose PCOS. It's not a thing that we normally check in PCOS, but because it is produced in preantral and small antral follicles in women by granulosa cells, it can be highly elevated in women with PCOS. So if you have an accidental lab finding of extremely elevated AMH, then you might think about PCOS, and that would mean that you can look for it further. But normally it's a hormone that we use as a predictor of ovarian reserve in a woman. So obviously it's only there until menopause and is not a part of the lab evaluation of PCOS. And I think, yeah, so one last thing that I'm going to talk about is the complications that we talked about, such as sleep apnea, hyperlipidemia, and other complications of PCOS. Their management doesn't differ from the same conditions without PCOS. So they should be referred to the professionals that deal with these complications. So questions now? I think it's been an hour of the presentation. And if there are any questions, then I'm willing to take them.
Before we go to the questions, actually, if I can just mention for the rest of the people, if we can go to the next slide with the rest. Yeah. Just for your information, this is our calendar for the rest of the month and the next month. We will be announcing some more events later on, but for now, this is it. Our next lecture would be about men's health after a full month of women's health lectures. And then we will have some sort of role models lecture with Dr. Marta and so on. But we can go back to the questions. Before moving to the questions from our Zoom call, there is one question that we have received from our YouTube Live, which says, can PCOS be related to hypothyroidism and Hashimoto syndrome?
No, I don't think so. Okay. I think they can be two coexisting conditions, but I don't think that's something that can either cause that or Hashimoto can cause PCOS, because they don't really overlap in any way. Do women with PCOS get pregnant at later age more often than those without PCOS? Since their menstrual cycle tends to normalize with age. No, that's their menstrual cycles normalize with age because they are nearing menopause, and the levels of androgens, kind of like they are depleting their ovarian reserve. So because of their ovarian reserve is depleted, as we talked about, the preantral and antral follicles are the ones creating the hyperandrogenism in them. So the less follicles then they have later in their life, the less androgens they have, the more normal cycles they have. It doesn't, but still they have a lot less ovary, a smaller ovarian reserve, a lot less follicles. So no, they would have a lot more problems getting pregnant at the age of 40 as any regular woman would, because by the age of 40, you are considered at a high risk of not being able to getting pregnant spontaneously. After pregnancy and childbirth, can a woman use further use combined oral contraceptives? Yes. Obviously, if she is lactating, if she wishes to breastfeed, we use the mini pill, what I talked about, with a small dose of progesterone, only progesterone pill. After she stops lactating, we can get her back onto combined oral contraceptives, or if she wishes to, then just have her PCOS managed as I talked about, as where we just induce menstruation. We can also do that, but yes, after pregnancy and childbirth, she can go back to using combined contraceptives if she is not breastfeeding, in which case we use contraceptives that are not combined, but just mini progestin pill. Can you induce ovulation every month, or do you have to have pauses? Yeah, you can, unless you get pregnant in that first try. We usually induce ovulation where we kind of look at the ovary, how it's creating that dominant follicle, and then we can also give them an injection which kind of it's a recombinant HCG that almost guarantees that the egg will be in that dominant follicle. So then we kind of also plan for people, say they come into our assisted reproduction clinic, we plan for them to have intercourse certain days, and then if they do not get pregnant at that time, we try again next month.
We have also one question from our private messages. It says, can leaving PCOS untreated cause infertility, not in the sense of just having difficulties to get pregnant, but maybe permanently damaging the ovaries?
No, not really, because the ovary is not damaged in PCOS per se. The ovary can appear as having like a thicker capsule, and that is not something that damages the ovary per se. And you can still have the same like ovarian reserve, because it's not that you are depleting the ovarian reserve with polycystic ovaries, because even in normal menstruating women, every month we have certain, like a cohort of ovaries that, not ovaries, oocytes that go through menstrual cycle and then die off, just with one of them being the dominant follicle. So you won't become infertile with just PCOS because you have untreated PCOS, but untreated PCOS is why you are infertile or having trouble conceiving, because you just do not ovulate. And I have 3 more questions here. How long can you take the medication for inducing ovulation for? As long as you need to induce ovulation for. You take it for only 5 days of your cycle, and usually it's quite effective with inducing ovulation. So like 3-4 cycles, they get pregnant, they have the baby, they come back for a second baby, maybe not. Can these cysts grow larger? No, not really. We are talking about, I've talked about the fact that these are not really cysts. They are the tiny little follicles whose growth has been arrested at the size of like 5 to 9 millimeters. The ovaries can be larger because there are more of those like tiny cysts, but the cysts cannot grow larger. And there is a question of any specific treatment for PCOS-induced baldness. Oral contraceptives enough? So PCOS-induced baldness is a male pattern baldness, again caused by higher levels of androgen in your bloodstream. So as soon as we lower that with combined oral contraceptives, your hair should be coming back. So again, it's the same treatment of combined oral contraceptives or spironolactone added after 6 months, but it's going to take a lot longer for the hair to grow, obviously, because I think, and that's a dermatological question, you're going to have like baby hairs for a very long time until you have at least some length to them. Could the ovulation be more painful for women with PCOS? That's a good question. I don't think so, because again, they ovulate maybe once every 3-4 months. Maybe the rupture of the capsule can be slightly more painful, but normally painful ovulation is something that we see with usually like more slender women or women with like adhesions, mostly because painful ovulations are not caused by the ovary itself, because ovaries are not painful in like, you cannot really like feel pain in the ovaries, but the pain that is happening during ovulation is caused by the tiny amount of fluid that kind of irritates the peritoneum when it comes in contact with it, and that could be the ovulation pain. So I don't think they can have more painful ovulations, but obviously if they do ovulate also like 4 or 3 times a year, they can be painful, but I don't think that's the reason why. What if a woman takes COC, then decides to get pregnant at about 35 years after having the baby? Should she start taking COC again to prevent endometrial cancer, knowing the risks of COC after 35 years? I think it's a question of each patient. Again, we can prevent endometrial cancer with just inducing menstruation with progesterone in the second part of the cycle. There are still some combined contraceptives that you can take after 35 years, obviously with the least amount of estrogen, and only in the case of you not being a smoker. But if she wishes to stay on a contraceptive pill that gives her A, contraception, and B, protection from endometrial cancer, we can put her on progesterone-only pill, which can give her both. I hope that is enough of an answer. Can diet and exercise cure PCOS without oral contraceptives? Again, there is no cure to PCOS because it's usually a problem that starts with your pituitary gland and the imbalance of the production of FSH and LH. But diet and exercise, as I said, are the first tier of treatment that we advise every woman to do when she's diagnosed with PCOS. It can improve even a 5 to 10% body mass reduction can improve their symptoms drastically. So yeah, it cannot cure it because nothing really can cure it, but it can definitely cause an improvement in the symptoms.
Perfect. Thank you so much. We'll see, maybe we'll receive another question or anything, but thank you very much for your time. It was a lovely and very informative. Oh, yeah, we do have another question, but it was a very informative lecture and we're very, very.
What is the pathophysiological explanation for the insulin resistance in PCOS? It is believed that there is a link between the excess androgen production and insulin resistance, and also the fact that some women can be obese and that can lead to insulin resistance, but there is no like direct link that I can tell you why is it happening, because again, we're very still unsure on the actual cascade of pathophysiological causes of PCOS, or like where the cycle begins, if it begins with the weight or the weight causes, if the weight causes PCOS or PCOS then causes weight.
Perfect.
All right. I hope that was comprehensive, a little bit at least.
It was great. And it was very good that we could have this conversation because, as you said, research is still quite not that advanced, or we don't have that many, let's say.
I'd say it's just like really inconclusive
Okay.
about quite a few things. We know how to treat it, how to treat the symptoms,
Yeah.
but then again, there are quite a large variety of diseases in other specialties, not just gynecology, that only have treatment of the symptoms, not treatment of the cause. So unfortunately, PCOS kind of falls into that category as well.
Okay. Thank you very much.
You're welcome.
So yes, thank you, Doctor, for today's lecture. And yeah, thank you everyone for attending, and we hope to see you soon in the next following lectures we're going to have. Have a great afternoon, everyone. Bye-bye.
Thank you. Bye.